record to the cloud. Pardon? Okay, we're going to record to the cloud, and I will record not only the presentation, but also the questions that you have at the end. I will turn the record button off when we open the meeting for discussion. There's some new people on, and if you want to have some chatting with us, some fellowship, we'll do that at the end of the speaker's time with us. And okay, so I hit the record button already. And welcome to today's speaker. So, Dr. Rivas, do you want to, I have screen sharing up. Do you see that? And can you put your presentation up?
Yes, Andy, I need you to stop your screen sharing and then I'll be able to do it.
Stop my screen sharing. Okay, good. I shall do that. And then I see all these beautiful faces. And then Dr. Rivas, if you could, please, you just introduce yourself a little bit. I don't know much about you.
Sandy, can you enable the participant screen sharing? Only you have the.
Yeah, I thought I did that. I did that when I set the meeting up. So let's see. Let me go to share screen. Let me see. No, that's not it. Close that. Who can see this live transcription? Who can see it? Huh. I thought I did that when I set the meeting up, that all participants can share. Okay. Enable waiting room. Yeah, I can't find anything. Darn it. I have share screen. And then, oh, here it is. Duh. Sorry. I think this should do it.
Yeah, perfect. Great.
As you can see, it's been a while.
There we go. All right. There you go. Can you see my screen there?
Perfect.
All right. Well, thank you, everybody. And thank you, Sandy, for once again inviting us to participate in this symposium. I'm going to be talking about sequential or second implant for the Medicare population. And to begin with, I want to introduce myself. I'm Alejandro Rivas. I'm the Chief of Otology and Neurotology at University Hospitals. I joined University Hospitals about 1.5 years ago. And I come from Vanderbilt, where I practiced for over almost 12 years. And there I was the chief, I was the associate chief of otology and neurotology. And then when Dr. McGarrian at University Hospitals went up to becoming the CEO for the system, he recruited me to come over and start and join the group. So we are a group of 4 surgeons and 14 audiologists, and we are distributed throughout Northeast Ohio. And we're very happy to be here. So this is my disclosure. I'm a consultant for Cochlear, Grace Medical, Stryker, and Cook Medical. And when we talk about cochlear implants, it's very important for us to talk about what is the impact of hearing loss in the world. And we know that about 466 million people worldwide have disabling hearing loss. We also know that about 1 in 3 people begin experiencing hearing loss between ages of 65 and 74, which is again, the Medicare population. 10,000 people turn 65 every day, creating a large population who will benefit from clinical research, therapeutics, and certainly improvement of their hearing. And if we look at 2050, we estimate that over 900 million people will have disabling hearing loss, which is huge. Unaddressed hearing loss poses an annual global cost of 750 billion. That is tremendous. So when we look at under those parameters, then we need to really talk about the impact of cochlear implant and what its candidacy means by the different regulators. So being FDA approved doesn't mean that Medicare will approve a cochlear implant or that an indication is approved. A device, for example, a cochlear implant can have an indication, FDA indication approved for implantation, but Medicare does not necessarily follow those parameters. Medicare follows the CMS guidelines. And unless the guidelines at CMS are changed, the Medicare is not gonna approve newer recommendations, which is different than private insurances. Private insurances follow FDA regulation, and so private insurances will change their guidelines based on FDA approvals. An example, Medel and Cochlear Americas have an indication for cochlear implantation for single-sided deafness. So patients with good hearing in one ear and deafness in the other ear. So those now up to a year ago, or 2 years ago, or 3 years ago, most private insurances were denying cochlear implantations under that indication. There are some insurances that just now 3 years or 4 years later are starting to change their guidelines and saying, yes, we approve cochlear implants for deafness in one ear. And so there's a few, very few. For example, Aetna is one of them. And that's just an example. And that's in terms of private insurance. Medicare is not there yet. So under Medicare guidelines, we cannot implant patients with single-sided deafness, meaning with deafness in one ear. Now, in terms of candidacy for implants, the FDA approves, or when you have bilateral bilateral hearing loss, they approve center scores better than 50%. Okay, what that means is that you need to not be able to understand speech less than 50% of the time, and we using a hearing aid on the best aided condition, meaning that you have to be using a hearing aid and you're not hitting 50%. Private insurances, the scores goes up to 60. Okay, for Medicare is only 40, and so that obviously impacts what the options that we can provide. Now, the good thing is that the candidacy criteria does not specify if a patient gets scores of 50% in noise or in quiet. You all know that the world is not quiet. We don't live in a bubble. We do not live in a audiology booth, which is where these tests are done. We live in the world, and the world is very, very noisy. And the good thing is that Candidacy doesn't specify how to test them, if in noise or in quiet. So when patients are struggling in noise, we can test them in noise. If they hit 40% or worse, they're still candidates. Now we know that the benefits of cochlear implantation, there are many. There's better hearing in quiet, better hearing in noise, not perfect, but better hearing in noise nonetheless. Better sound localization, improved literacy, especially in the pediatric population. It has a big impact on cognitive in cognition, and so people who cannot hear become isolated, and isolation causes cognitive decline and an early onset of dementia. So it's very important as we grow older to maintain our social activities and maintain our interactions with the world so that our minds continue to work. Social and cognitive functioning, we talk about that, better educational achievements and employment and socioeconomic opportunities. Now, the predictors of cochlear implant outcomes. So duration of deafness is crucial. The longer you're deaf in a ear, the more likely the neurons on that ear to become stagnant, meaning they become lazy. It's like nerves are like muscles. If you work out and you do a lot of exercise, your muscles become very strong. Same with nerves. If you use that nerve regularly, those neurons are bulky, healthy, and you get better hearing results with cochlear implant. And that's why it's very important to always wear hearing aids until the time of implantation, because might not benefit much, but you at least stimulating a little bit those ears. The preoperative hearing, the same reason. The better the hearing you have when you get an implant, the better you will do afterwards. And the reason is because your nerves are stronger. You have been stimulating them earlier, so when you get an implant, you will do even better and faster. And obviously, the device variables, the most important is the duration of implant. The more you use the implant, the better you'll do. If you use the implant during all waking hours, then you're gonna get the maximum benefit from that implant. So we talk about expanding indications for CI. In the last time I was in this group, we talk about expanding indications of cochlear implants. The fact is that now we're doing implants with patients with hearing. So for example, this is an audiogram. And for those who are familiarized with this, on top, we have frequencies. So low tones, 125, high tones at 8,000 Hertz. And here we have volume. What we plot here is the minimum amount of volume that we need to give a patient for them to give a tone. So when cochlear implants started, we used to have complete deafness. Now we have good hearing in the low frequencies, poor hearing in the high frequencies, and we implant these patients because we move primarily from implanting based on tone hearing to implanting on speech understanding, which ultimately it's what matters. But if we're going to be implanting patients with hearing, we need to be very, very careful to preserve all the structures and preserve what we call this is the residual hearing. So there's multiple mechanisms of trauma when we do surgery. I'm not gonna go through those, but I'm just gonna show you. But ultimately what happens is that when we put a electrode that goes all the way into the cochlea, and here is the cochlea, okay, you can damage some of the internal structures. For example, this is a photograph from Briggs that shows a implant that is in the right place. This is the cochlea. When it's cut, is a mid-modular section, it's called, because we cut it in half and look at it. You can see the implant right here and right here, but it's causing a little bit of trauma. It's pushing right here against the structures and the lateral wall. So this is a little bit of a traumatic insertion. Obviously, when we do, as a surgeons, do traumatic insertions, if a patient has residual hearing, we can lose those low frequencies. That doesn't mean that the implant doesn't work. No, electrically, it will get the same outcomes. But without using it, the low frequency hearing that they have might get lost. Ultimately, the goal is this. We have two little compartments in the ear. The red one is called the scala tympani, and that's where we want to put it. And if we're able to put implants all the time in that scala tympani, we will be very successful at preserving hearing and at getting good outcomes. If we translocate, if the implant goes from the red scala to the blue scala, it's called the scala vestibuli, then that's when the implant, we can create trauma inside the cochlea. So we've looked at these results. This is speech perception scores, sentence and words. CNC's words scores. AZ Bio is sentence scores. And you can see here that when we put that implant in the red area, they do much better compared to the blue area. And as I mentioned, we've described that we're able to preserve hearing with cochlear implants. And this is just an example of a patient that had hearing in the low frequencies, even almost normal tones is above 30 decibels. And I'm being a little bit lenient about this, but I don't want to be a stickler. So let's say that 30 is normal. This patient had normal hearing at 30 decibels right here, and then a severe loss and profound loss in the high frequencies. And after an implant at activation and beyond, we preserve not all the residual hearing, but some of it. So this patient can use what's called a EAS processor, electroacoustic stimulation, which means that we put a processor that stimulates the high frequencies electrically, which is what the cochlear implant has. And that implant has a little attachment that stimulates the low frequencies acoustically. And that gives patients better hearing in noise and better hearing, better appreciation of music, for example. And this is more patient. That was just patient. The little dots here is just shows many patients that we've done. And basically what it shows is if we preserve all of the residual hearing, they would be in the black line. And the further we move away from that black line, the more the changes in that residual hearing. And what you see here is that most patients, we preserve hearing within 10 decibels. And 10 decibels mean it's accounted for about being down here. So going similar to this graph, we went from 30 to 40. And so that's the rule for most patients after surgery, on activation after surgery, and 12 months after surgery. Activation 6 months and 12 months after surgery. So that maintains over time. And the reason why that happens is because when we put implants this day, we get inside the scala tympani and very close to the neuronal structures, which is what you see here in yellow. If an implant gets very close to the modiolus, then we're going to get very specific stimulation to the neurons, which is ideal, and patients do better. by being close to the modulus, we can improve speech understanding by sometimes by 10, sometimes by 20% points. So then you're gonna ask, well, okay, so my partner, Dr. Mari, did the surgery and I got a fantastic result and I'm doing very well with my cochlear implant. I already had a good result. My hearing is good with one cochlear implant. Why do I need another cochlear implant? What's the benefit of it? Well, the why. We know that the vast majority of cochlear implant users do very well understanding speech in quiet, and they have a significant improvement of quality of life. However, we also know that they do struggle, and it's not a rule, but they struggle in knowing where sounds are coming from, because they all seem to be coming through the same ear, the ear that they're hearing better from, which is typically the cochlear implant side. And they also have difficulty in everyday situations, meaning noisy, meaning environments where there is reverberation. So we know that normal hearing individuals have two ears, and hearing through two ears is called binaural hearing, okay? And binaural hearing allows you to localize sound and understand speech and noise. And that happens through several mechanisms. One mechanism is called the head shadow effect. The second is the binaural squelch. The third is the binaural summation. And I'll explain those briefly. I'm not going to go too deep into it, but I'll explain those briefly. All of them use two major things, what we call ITD, intraoral time differences, and intraoral level differences. So how time difference is the difference from the sound getting to one ear and the difference from getting to the other ear. So if you're on my left side, the sound is going to get my left ear first and hit my second, my right ear second. And our brains, when we hear it with two ears, are able to notice that difference in time. Intraoral level differences is the difference in loudness. If the sound is coming on the left side, when it hits my left ear, it's going to hit the left ear louder compared to when it hits my right ear. And again, our brains are able to determine those two differences. So patients with implants in both ears, actually, they can identify intraoral level differences. So the loudness of the sound, depending on the duration, makes an impact on patients with bilateral implants. And that's why they do better in the head shadow effect, in the binaural squelch, and binaural summation. What is the head shadow? Very simple. You see here when the sound is coming on this side of the head, in this case it will be the left ear, when the noise is coming on the left ear, but the signal is coming out directly, the head shadow, the whole head is going to prevent the other ear from hearing perfectly. So if you have an implant on the left side, well, there's no problem. But if the implant is in the left and people are talking to you on the right, well, that's a problem because you have the whole head that is an obstacle to hear properly. That's the head shadow effect. Then there's something called the binaural squelch. When you have one ear, okay, you get sound, you get two things. You get what you want to hear, speech from other people, but also you get the noise from the surrounding, and everything comes through the same ear. And since everything comes to the same ear, everything goes to the same area on the cortex, on the brain. And then it's very difficult for the brain to separate those two signals, noise and voices. Now, when you have two ears, then what happens is what you really want to hear comes through one ear, and I'm at a much lower difference, at a much lower volume. It comes to the opposite ear. Okay, same as the noise. And so by doing that, the sound, the brain can identify the differences in volume when the noise gets to the brain, to the ears, and when the signal gets to the ears, and is able to subtract that information and subtract noise from signal, noise from voices. That's the binaural squelch. And this binaural summation, that's very simple. If your brain gets the information from the right ear, and it also gets it from the left ear, then the brain has a confirmation of what people are saying, because they're getting inputs from both sides. That's the binaural summation. So there's a lot of data for many, many years now showing the benefits of bilateral implantation on patients with hearing loss. And so this is a study, look, 2000, looking at comparing patients with binaural cochlear implants versus monaural cochlear implants. And what you see is that when we look at scores in words, the patients with binaural cochlear implant, with bilateral implantations do much better compared to unilateral implantation. And here, this is words that they're scoring, and here there's sentences. This study was done in Germany, and so that's why this HSM is a German test. But again, patients with binaural hearing do better compared to monaural hearing. This is a study done here in the United States, and it's actually one of the studies that was used to approve for the FDA to approve bilateral implantation, which is this is a study where you have in the dark, you have when patients that implanted the worst ear. In white, you have patients that implanted the better ear, and in the last one, the excess bar is patients who had bilateral implantations. And you can see that in all conditions, when you implant the worst ear, you do a little bit worse compared to the better ear, and you definitely do much better with both ears implanted. And that is true at 1 month, 3 months, 6 months, and 12 months. And the reason, if you want to, the reason why patients that get implanted in the better ear do better is because they have more neuronal survival. So then question becomes, okay, let's say that I have, so that's very important. Let's say that this is very important because if I have an implant in one ear and I have no hearing whatsoever in the other ear, well, yes, probably 2 years when I have one that doesn't hear anything, if I get an implant in the other side, I'm going to do better. That might be potentially obvious. But what happens when we have hearing aids? What if I have an implant in one side and my speech understanding is bad, but I still get benefit from a hearing aid, a little bit of benefit from a hearing aid? What we saw when they did this study by Litovsky is that looking at binaural cochlear implants, meaning cochlear implants in both sides, they do better compared to monaural hearing. And binaural cochlear implants, do better than monaural cochlear implants. The closer, the shorter, the smaller the graph, the better they do, because we're looking here at degrees of hearing. What about hearing in noise. What if the sounds are presented if the noise is coming from different locations? So again, this is a study by Ricketts that was done at Vanderbilt there. And what Ricketts showed was that here's how this study was conducted. The patients were receiving noise from different locations at the same time, not one location, multiple locations. So noise from 30 degrees, 105 degrees, 180 degrees, 250 degrees, 330 degrees. So what that means is noise from a real living situation in a noisy environment all over the place, and the speech coming in front of you. And so what he showed is that when we look at patients that received this test, those who had left-sided implantation only got this result. Those who got right-sided got this result. And patients who had bilateral, they got better. Here we're talking at single to noise ratio. So the lower the point, the better they do. Normal hearing patients, they are at around 0 to 2% or 0 to 2 decibels. Okay. The other thing here is that on this test, a decrease in 1 point is equal approximately to 10 decibels of improvement. So if you compare here, for example, this patient who got, or this group of patients who got unilateral implantation compared to the bilaterals are doing 20% better than the unilateral. And if we look at the ones that we implanted the better ear, again, bilaterals do better. And that's true for sentence. This is a sentence test. This is true for word testing. And this is also true over time. Bilateral implantations in general do better. Now, there is a point, there's something called sequential versus simultaneous. So what if should I get an implant in both eyes? If I'm deaf in both ears, should I get an implant in both sides at the same time? Or should I get an implant one first and the other one second, maybe 6 months later? Well, it depends. If we talk about children's are different, especially children who are born without hearing. But adults, and since we're talking about Medicare population, adult patients. For adults, I feel that it's better to do one ear first and do the other one second, okay? Why? Because more frequent than not, every patient can hear better in one ear compared to the other, And it doesn't matter. These are new experiences for patients. People are not they don't know necessarily how good they're going to hear with an implant, and so it makes a lot of sense on adults to get one implant first, make sure that they like that implant, make sure that they have good progress with that implant, and then get the other implant 6 months later. So simultaneous is at the same time. Sequential is sequential is one now, the other one 6 months later. What we see here is that, so on this study, what they did is in the blue, you have the simultaneous implantation over time. So you have at 1 month, 1 year, 2 years, 3 years, and 4 years after implantation. Those patients who got sequential implantations, they got it at this 2 years mark, okay? And so what you see here is that when we look, for example, at speech understanding in noise, when the noise is coming at 0 degree, you know that it doesn't matter. If you got your implant at the same time or at a different time, they get very similar results, okay? What happens when if we implant the worst ear, okay, in the worst situation possible, okay, and probably the worst situation is when the noise is coming on the implant side. So when the noise goes in the implant side, you can see here that those who receive simultaneous implantation is in blue, and obviously those, and over time, the ones in green, they do the same. What happens with the best performing situation? There's no difference. What about localization of sound? So in green is the patients that have the simultaneous implantation of both implants. So those patients do very well when the sound is at 60 degrees. And these are patients with only one implant, and they get implanted at 2 years. And look at this. Once they get implanted at 2 years, the sequential implant goes up to what the bilateral implantation patients were doing. So they do better immediately. Second one, here at 30 degrees, when this localization of sound at 30 degrees, same thing happens. And at 15 degrees, the same thing happens. So the bottom line, and when we look at speech intelligibility in quiet, also, the patients do very similar from simultaneous implantations versus sequential implantation. So that's why, since there's no big difference, I recommend bilateral implantation to everybody. But in adults, I feel that it's better to get an implant, be happy with their implant, be confident of the improvement, and then after that, move forward with a second implant. So let's discuss the patient. So let's see that this is me, ARC. It's not me really, but this is from one of my patients, but let's say that it's me. And so this is a patient who came to me. He had been wearing hearing aids for 20 years. He still had good hearing in the low frequencies. So normal hearing, if you look at here in the low frequencies, and in both ears, excess is the left ear, circles are the right ear in the different frequencies, and everything goes down in the high frequencies. When we test their speech understanding, the left ear only was getting 8% of words. When presenting sentences in quiet, only 30%. And obviously in noise, he bottomed down, 0%. The other ear was better, but wasn't great. The words he could understand 61%, that was okay. Sentences, 44%, but in noise, that dropped down to 30%, 37%, which again, we don't live in quiet. We don't live in a booth. We live in noise. And so he decided he depending on his right ear. So obviously we went with the left ear first. Okay. And he has good substrate, because if he has hearing in the low frequencies, we know that the neurons are still strong on both ears. And look at that. So this is after surgery. He still has his residual hearing in the low frequencies, but now we're able to stimulate the cochlear, electrically, the mid and high frequencies. So this patient is getting an EAS processor. He's hearing with the acoustic piece with a hearing aid piece in the low frequencies, and with the electric piece in the high frequencies. And he went from 8% in words to 100%, from 30% in sentences in quiet to 96%, and sentences in noise, he went to 89%. The right ear, we didn't do anything, so his scores are still the same. But he still wanted to have even better hearing in noise, okay? And better sound localization. So, and this patient, ARC, was 70 years old. So we still decided to go for the right ear. And so I did this kit not too long ago. And so we don't have the results still, the speech understanding scores yet, but we do have the tone hearing. And now here, when we, at least so far, and we're only about 1.5 months out, he still has all of his residual hearing look at that. All of the residual hearing in the low frequencies, we just went down by 10 decibels and it's still healing. So I expect this to come back up to the way the other ear is. And if this maintains, he's going to have a fantastic hearing results in both ears, which will allow him to have better hearing in noise, better appreciation in music, and better speech understanding in noise. So what happens with bilateral implantation? So to be honest, I didn't make any specific slides about what happens, because it's variable from state to state. Okay. When I was in Tennessee, for example, when I was in Tennessee, everybody would get a bilateral implants. It didn't matter if it were Medicare or non-Medicare. They were in Tennessee, the Medicare of Tennessee was approving bilateral implantation and reimbursement for them without any problem. When I came to Ohio, that was a little bit different. And the fact is that, and the difference is this: when patients, when we have a commercial insurance, before we did an implantation, we send documentation to the private insurances, and they say, yes, you can implant, and or no, you cannot implant. But we have somebody that we can ask about it. And if they say yes, we're safe. Everybody's safe. We're able to do the implant. On the Medicare, we don't have anybody to ask. We cannot ask for permission. We can only follow guidelines. Okay. And for many, many years in Ohio, patients who received bilateral implantation, we would do the implantation, and Medicare would not cover the implant. Would not cover the implant because they would deny it, because they already have a second implant. However, under all of the policy of CMS, nowhere in there says that patients cannot get bilateral implantation. Okay, it just says that they need to meet the criteria in the best aided condition. So if a patient in the best aided condition is still not getting significant improvement, they still are able to get bilateral implantation. And so under that paradigm, since I moved to university hospitals, we have been moving towards getting our Medicare patients bilateral implants on those who desire and those who want to, because it's because there's no, in theory, there's no restrictions. Now we cannot implant everybody immediately. We need to make sure that that we document appropriately our bilateral sequential Medicare population, and make sure that Medicare reimburses for at least the cost of the implant, because otherwise we won't be able to service the needs of our program, and our program would get bankrupt. But there's all the states that are doing it, and we're moving on that direction towards being able to get implants for our Medicare populations bilaterally. So the fact is that so far we've done 3 implants this year on the Medicare population, and if as I hope that it will occur, that we get the appropriate reimbursement and not get the claims denied, we will open the gates to our Medicare population for bilateral implantation. And the reason is because we're a data-driven program. We're always available to help all and any patient with hearing disabilities, and I'm completely engaged in making this a priority, and we're doing it. And we want to be able to find the appropriate solution for each person. So with that in mind, we have different access points throughout Northeast Ohio, which is in gray is here our access point that we can provide. And obviously this is done under the collaboration of all of our team members here in this slide. And with that, I will open the forum for potential questions.
Thank you very much, Dr. Rivas. I'm going to first, there's a lot in the chat box, so let me check that. Okay. Okay, from Allison, she says, for those implanted with their residual hearing maintained, does a patient wear a combination hearing aid cochlear implant on that side?
Yeah, so those patients that have residual hearing, they wear the same processor, okay? But you know how the processor finishes in a little hook right here? Instead of a hook, so patients with residual hearing, they wear, instead of a hook, they wear a little earpiece that comes down and into the ear canal, okay? So the processor does both. That's called an EAS processor, electroacoustic stimulation processor. Okay, so they don't have to wear two, they just wear one single processor available, one single processor that does both things.
And Allison, can you, is that a sufficient answer, or would you like to follow up?
No, that's sufficient. Thank you.
All
I
right,
just,
thank you.
yeah, okay.
All right, let me go to the next question.
So, Sandy, if I may, I
Sure.
would like, and that's very important. That is very important. If you not, for example, if a patient is not hearing speech understanding, but they have a little bit of hearing or a little or quite a bit of residual hearing, those are the best candidates to implant. Those are the patients that will get to 100% speech understanding very fast because they have a lot of neurons left. So my patients are always they're always afraid of implanting an ear with hearing because they don't want to lose what they're hearing, what the hearing is left. But there's especially in adults, there's 2 years. There's always 2 years. And so I always encourage my patients to try one, do an implant, and like the case that I presented, preserve their hearing. We are able to preserve residual hearing in 70% of the cases. So that's a very good, those are very good outcomes. And so they would do fantastic with an implant and preserving hearing. And then you can move to the other ear if you already preserved the hearing in one.
Thank you. I'll close that. Let me go to the next one. Okay, it's not opening. Hang on here. Okay, let me try it here. There it is. Sorry. Okay. It's disappearing. It was on and then it wasn't. Okay, let me see.
There is a question here that
Can you
says,
see it?
is
If
it
you can see the chat, go ahead and take over.
okay? Is it standard to implant the worst ear first? No, It is not standard to implant the first ear worse. If we give the option to the patient to implant the worst ear or the best ear. Primarily,
Okay,
Larry, please mute your
sir,
phone.
can you please, can everyone please
For as well, we
mute?
appreciate your insight,
Mute.
and we will have more with team coverage coming up at the top of the hour.
Can you, Larry, can
Yeah.
you mute yourself?
I'm trying.
okay. So is it standard to implant to the worst ear first? And the question is no. We give our patients the option of implanting the better ear or the worst ear. If they are equal, and say you have the ears are worst, then more frequent than not, I ask the patients, do you drive? When you drive, do you drive with somebody next to you? And if the answer is yes, if they say, yes, I'm in the driver's seat, for example, then I say, get an implant on the right side first, because then you can hear the person who's on the passenger seat better. If you typically are in the car and you're on the passenger seat, then I'll tell you, well, use it in the left ear so you can hear the driver better, if they're the same. Most patients prefer to do the worst ear before doing the better ear. And the reason is, especially if we're moving towards implantation, eventually moving to sequential implantation, meaning one implant now and an implant 6 months later, then we implant one ear, the worst ear first, just to not put in jeopardy the better ear. And as I said, patients sometimes are afraid of implanting the better ear because that's what the ear that they depend on. And more frequent than not, and I'm talking about 90% of the time or better, the ear that we implant, even being the worst ear, becomes much better than the better ear before surgery.
I do have a quick follow-up question on that, please, which is that as far as the results in the cochlear implanted ear itself, do you get better results? I mean, if you're not looking at preference because of worry about losing your good ear, but just sheer performance kind of, do you
Yes.
get better results if you're implanting the worst ear or
Yes.
the better ear?
Yes, the better ear usually gets the better results.
Okay.
And we individualize patient to patient. For example, okay, if a patient lost their hearing 50 years ago, okay, and has gradually been losing hearing in the better ear over time, and that patient is not receiving good speech understanding, on that particular case, I will go to the better ear first, because that other ear has not heard for so long that I wouldn't be able to know, or they might not get a very good result because of the time of deprivation.
Thank you.
All right, I'm gonna keep going here.
I have a question for you.
Yes.
I'm just baffled by the fact that Medicare, their line is 40%. That makes no sense to me, because usually people are in Medicare are the ones that need the cochlear implant the most. So, what's it going to take for them to change their criteria?
We are working, and we is all of hearing specialists and the cochlear implant community and otologists and audiologists are working diligently with the American Cochlear Implant Alliance, with the companies to move that forward. We've put out multiple position statements from companies, from the American Board of Otolaryngology, from the Cochlear Implant Alliance, from multiple places. We put in data over and over again to make that happen. Okay. Allison is another. For those implanted with the residual hearing maintain. Oh, I already answered that one. Hello, I don't know if it was mentioned, but can you get a second cochlear implant in the other ear at a later date? No. Yes. So what I was talking. So the question is, can a patient get an implant at the same time, or can they get an implant at a different time? So under Medicare, you get one at a time. You don't get one at the same time. Okay, because you need to prove that we can do an implantation in the best 8A condition. Okay, and so what that means is that we need to do an implant first, check how the patient is doing with the new implant, and then move forward with the second implant on the other side. That's for that is specifically for the Medicare population. For commercial insurance, we can ask for bilateral implantation at the same time if patients want that. I hope that answered the question. So Barbara is asking, I had a cochlear implant 4 years ago, not a great result, still have to lip read. Would a second implant improve things? What if it's the same poor result? Yeah, I mean that can happen less than 10% of the time. You know, where you get an implant and you don't get a good result. And so the question would be, why? Is there any reason before they did the first implantation why you had a bad result? If you had meningitis, for example, and lost your hearing, those patients do worse. If you've not heard for 30 years, 40 years, those patients don't do as good. If you lost your hearing and you got an implant within 10 years or you were hearing aids for a long time, but still stimulating and got the implant within 10 years, most patients do well. And so I would before going into the other ear, there's two options, to be honest. There's two options. When a patient does not get good results, there's two options. You can go to the other ear with the best technology available, which is much better than we used to have, not necessarily 4 years ago. But the other option is consider a reimplantation. Okay, sometimes there's something called device failure. Cochlear implants are electronic devices, and like any other electronic device, they can fail. And there's two types of failures. Heart failure, which means that the implant is dead, does not work at all. Soft failures means that the implant works, but does not working as well as it should. And so before moving to an implantation to the other side, if you had a bad outcome, I would consider reimplanting that same ear, because that could be a soft failure. Do cochlear implants help with whispering? Whispering, that's a tough question. So it helps with whispering, on being able to hear the whisper. But obviously when you're hearing impaired and you have a cochlear implant, you eventually can get to very close to normal levels. So you would be able to understand when people are talking or are whispering to you when you're wearing a cochlear implant. But the clearer the sound, the clearer the enunciation, the better. And if you're whispering, but the clarity is not going to be there.
Yeah, and the problem is that I'm working with children, and they really don't speak clearly. So yeah, okay, thank you.
Does Medicare only cover one implant? Well, it's tricky. That's what we're talking about. It's tricky. They're nowhere in the Medicare guidelines and the CMS guidelines. There's nowhere that say that they cover 1 year or they cover 2 years. Okay, and that's why it makes this difficult. The fact that they don't mention that they approve bilateral implantation, but they just within their guidelines they say one cochlear implantation in the best aided condition means that we need to test patients in the best aided condition before offering a second implant. And so the Medicare in Tennessee, for example, there's no issue. If you get you get an implant, and if you want a second implant, you go and you get the second implant, and they reimburse the institutions and the programs for that. In Texas is the same way. In North Carolina is the same way. In Ohio, historically, and I'm talking 10 years ago, that was not necessarily the case. They were not reimbursing for the second implant. In most programs in Ohio, we're not doing bilateral implantation on the Medicare. Now, there's one point that I've not touched, and I think it's important. There's something called Medicare Advantage, okay? Which means that you have, not that you have a second insurance, that you have Medicare with a specific private insurance. The Medicare Advantage plans are different. The Medicare Advantage plans are different because we can ask for permission. Under pure Medicare, we cannot ask anybody whether we can implant a patient or not. But under private insurance and Medicare Advantage, we actually can submit a claim before implantation and ask for approval. And they return to us saying, yes, this patient can get implanted, and then we can proceed. So that's the only point that I had not touched upon, which was Medicare Advantage. Oh, Lisa is asking here. So you're saying, as a person like myself who was born with a hearing loss and worn hearing aids my entire life, is not best candidate for implants, even though being told no more help with hearing aids? No. No, I'm not saying that. I'm not saying that. I'm not saying that. What I'm patients who've had a very long time of deprivation means that they're not wearing hearing aids at all. Okay, patients who've lost their hearing 40 years down the line, very long time ago. Okay, and they've not been stimulating that ear at all, so they're not wearing anything. Even those patients can get benefit from an implant. Okay, those patients, yes, they can get benefit from an implant, even if they've not heard at all for 40 years. However, they're not going to do as good as if they implant the ear that most recently lost its hearing. And so I hope that that's clear. I don't want, that is by no means that is the message. Cochlear implants on patients where hearing aids are not providing benefit, it's the absolute way to go. The question is which one to do first, better ear or worst ear? And if it's really long time ago that the worst ear have not been stimulated at all, then I prefer to go to the better ear. And the reason is this: if I implant the worst ear that has not heard for 40 years, and that ear doesn't get a great result, that patient will struggle with trying to get an implant on the other side. They will be afraid of what they have. And I know that the reason for that, for not having that perfect hearing, is that the deprivation has been very, very, very long. But patients, and so I go into the better hearing ear first in those particular situations.
Do we have any other questions for Dr. Rivas?
I had another question.
Go ahead.
Was in the chat, and I was looking for an explanation of what he meant by degrees, 30 degrees, 60 degrees in the slide that was talking about localization of sound. And I guess if you get a second implant, a secondary question on that is, how good does your localization of sound tend to become?
Okay. So the answer to that, it depends on, to be able to understand, to localize sound, you absolutely need 2 ears. You cannot localize sound if you have 1 ear, because all the sound comes through the 1 ear. And so you cannot tell where the sound is coming from.
Right.
Okay. So when you have 2 cochlear implants, then you can determine sound. When I talk about degrees, we know that normal hearing people, they can detect sound with a degrees. I talk about around me with
Okay.
a 6 degree of variability. Okay, so within 6 degrees, I can tell you where sound is coming from if I have normal hearing. When you have bilateral implantation, you can tell within 26 degrees.
Still not quite following that. I go bird watching, and if a bird calls, I can hear it, and I might point in the totally wrong direction. I have a cochlear implant and a hearing aid. So I just wondered if I got a second cochlear implant, whether I'd be able to tell where the tree it was in.
It depends on how much hearing you have in the hearing aid ear. If you have very little hearing left in the hearing aid ear, then yes, a second cochlear implant will help you localize sound better with that 26 degrees of variability. So what I mean is, when I'm in front of you, that is 0 degrees. Okay?
Okay,
When you are on my direct left, or yeah, on my direct left, that is gonna be 90 degrees. In the back
Okay.
is 180 degrees.
okay,
On my left is 270 and back to 0. So the variability for normal hearing people, the variability to be able to tell where a sound is coming from has a 6-degree range. Okay, which means that if somebody's talking to me with around me more than 6 degrees, I can tell where that is coming from. For patients with bilateral implants, with implants in both sides, that is 26 degrees.
Okay.
I hope it makes sense.
okay, we can move on. I don't quite understand, but that's okay. I don't want to go into that anymore, I guess. Thank you very much.
Thank you, Allison.
I just didn't want to
That was a
talk all
great
the
question.
time here.
It really was a great question.
Yeah.
I have trouble with localization too, and I have 2 implants. So I still have it. Do we need to go on to another question? Is there another question hanging out there? I also apologize. My chat box apparently is on the screen. I have the feeling that my signal is deteriorating because my mouth is not keeping up with the sound. So sorry, I can't close my chat box. So
There's a final
another
question. There's a final question here, or maybe not final, but another one. They're saying, will you talk about background noise in multiple people situations? Very difficult to hear with bilateral cochlear implants. So
Yeah, I do not disagree on that. You know, there are, as I mentioned, I don't know if you recall, I talk about 2 things, ILDs and ITDs, intraoral level differences, which is your ability to tell the difference in levels when a sound comes to the right ear first versus when they come to the second ear, to the opposite ear second. Your brain is able to adjust, to adapt that. Okay. And so cochlear implants, why people with bilateral implantation do better than people with unilateral implantation understanding speech is because cochlear implants allows you to determine that those 2 differences of loudnesses when the sound gets to one ear versus when the sound comes to the other ear. Your brain is able to subtract that information. Cochlear implants are still not able to get ITDs, intraoral time differences, not level, not how loud the sound gets to one ear versus the other, but the timing when the sound comes in one ear versus the other. And the reason for that is because our ears are an incredible mechanism that very fast, in a matter of milliseconds, When you hear a sound, it goes straight to your brain. Okay. When we use a cochlear implant, unfortunately, the sound has to go first to the processor, then from the processor to the implant, then from the implant to the electrode, and then from the electrode to the brain. So all of that is time. And so a cochlear implant is not as fast as our own mechanism. And so that's why, although patients with bilateral implantation, they do much better than patients with one implant, there's still reasons. And one of the major ones is that we cannot, cochlear implants still are not fast enough to close the gap on intraoral time differences.
Barbara Cotton has her hand raised. Did you have a question, Barbara?
My question was answered. Okay, thank you.
Okay.
Thanks, Sally, for noticing that. Any other questions? Thank you. Thank you. Great questions. I think the meeting went very well. I want to say to Dr. Rivas, this is the second time you wowed me, that's for sure. You just really have so much depth in terms of understanding what's going on with us and how these implants affect us. So I thank you again for spending your valuable time with us. And we hope to see you again with a different topic.
I would love that. Thank you so much, everybody, for staying during your lunch hour and joining us for lunch. We appreciate it, and thank you, because you guys, thank you to the group, because you do an amazing job in advocacy and keeping us connected, and being able to answer as many questions as we can for our hearing impaired population. So thank you very much.
Wonderful.
Thank
Well,
you.
I want to
so
follow
much.
that up with the fact that we realize this is our 13th year doing this. So we've been here for a long time.
Wow.
And hope to be here in the future. Okay, well, I'm going to put up, no, I'm not. There is I promised that there would be some time to talk with each other after Dr. Rivas left us. And what I realized is I scheduled this meeting I opened it at 11:30 and it's closing at 1:30. So we don't have any, next time I'll do it at 2:30. So I'm going to say goodbye to everyone and thank you all. Shirley Ann, do you have anything to say to the group? Because this is one of my teammates here. Go ahead.
No, I really don't, but thank you, Dr. Rivas, for a great presentation too. And no, I don't really have anything else to say. You said it all, Sandy.
All righty. All right, everybody. Hopefully this snow is going to go away fast. And the next time we see you, it'll be sunny. So bye-bye.
Hello.